Pelvic, hip, and thigh anatomy. The pelvic girdle is a bony ring. A bony ring is formed by two innominate bones. These are what most of us refer to as our hips. An innominate bone is a nameless bone. The pelvic girdle is an innominate bone that is made up of three distinct bones: the ilium, the ischium, and the pubis. Also, the sacrum and the coccyx are included in the pelvic girdle. The pelvic girdle is a basin-shaped complex of bones that connects the trunk and the legs and supports and balances the trunk. It also contains and supports the intestines, the urinary bladder, and the internal sex organs. The pelvic girdle consists of paired hip bones connected in front at the pubic symphysis and behind by the sacrum. Each is made up of three bones: the blade-shaped ilium above and to either side, which accounts for the width of the hips, the ischium behind and below, on which the weight falls in sitting, and the pubis in the front. We will go through and review some of the anatomy of the pelvic girdle. The circles in red indicate the anterior superior iliac spine. The ASIS, or anterior superior iliac spines, can be palpated easily if you stick your hands on someone else's hips and you let your hands rest on the iliac crest. Where your thumbs naturally fall is most likely the ASIS. They also stick out in most people and are a great place to bump into things, so we may develop a bruise here at one point or another. The circles in red indicate the anterior inferior iliac spine. The AIIS, or anterior inferior iliac spine, is not easily palpated. The AIIS is deep. The best place to palpate the area of the AIIS is in the leg crease where the thigh and the hip meet. The AIIS is underneath some very large muscles and tendons in the area. The circles in red indicate the posterior superior iliac spine. The PSIS, or the posterior superior iliac spine, are easily palpated. When you lift the back of your shirt up, you will most likely see two dimples in your lower back. These dimples are typically where the PSIS are located. The circles in red indicate the posterior inferior iliac spine. The PIIS, or the posterior inferior iliac spine, are not easily palpated, as they too, like the anterior inferior iliac spine, are deep to other tissues. The red circles indicate the area of the posterior inferior iliac spine, but they are not visible in this picture. We would need a picture of the posterior surface of the pelvic girdle to see the PIIS. The lines in red indicate the iliac crest. The iliac crest is easily palpated. Every time you put your hands on your hips, you are palpating your iliac crests. The arrows in red indicate the ischial tuberosities. The ischial tuberosities are sometimes referred to as the sit bones. The ischial tuberosities are easily palpated in the middle of the buttocks. It is easiest to palpate them if you lie on one side and put one knee up slightly, then palpate the lower part of your buttocks. You should feel a hard bone. This is where you sit. The circles in red indicate the acetabulum. The acetabulum are not easily palpated as they are deep to other tissues. The acetabulum is the location of the articulation with the head of the femur, which makes up the ball and socket joint of the hip. The circles in red indicate the obturator foramen. The obturator foramen are not easily palpated as they are deep to other tissues. The obturator foramen is a large opening created by the ischium and the pubis bones of the pelvis, through which nerves and blood vessels pass. This is a lateral view of the structures we just identified. You can also see the three individual portions of the innominate bone. The yellow portion is the ilium, the blue portion is the ischium, and the red portion is the pubis. Here is a medial view of those same structures we just identified. Looking at the hips from different angles can help you identify structures more easily. The sacrum is a large triangular bone at the base of the spine. It forms by fusing the sacral vertebrae together, S1 through S5. This fuses between 18 and 30 years of age. The sacrum has 3 different surfaces that are shaped to accommodate surrounding pelvic structures. Overall, it is concave, or curved upon itself. The base of the sacrum, or the broadest part and uppermost part, is tilted forward. The central part is curved outward towards the posterior, allowing greater room for the pelvic cavity. The coccyx, commonly referred to as the tailbone, is the final segment of the vertebral column in humans. The coccyx is formed by either 3, 4, or 5 rudimentary vertebrae. It articulates superior with the sacrum. Most anatomy books incorrectly state that the coccyx is normally fused in adults. In fact, it has been shown that the coccyx may consist of up to 5 separate bony segments, the most common configuration being 2 or 3 segments. The femur, or thigh bone, is the most proximal or closest to the center of the body bone of the leg, while the distal part of the femur articulates with the tibia and the kneecap, forming the knee joint. By most measures, the femur is the strongest bone of the body. The femur is also the longest bone in the body. The femur's length, on average, is 26.74% of a person's height, a ratio found in both men and women and most ethnic groups. The femur is categorized as a long bone and comprises a diaphysis, the shaft or body, and 2 epiphyses, or extremities, that articulate with adjacent bones in the hip and the knee. The angle of inclination is formed by the angle resulting from the intersection of a line drawn down the long shaft of the femur and a line drawn through the neck of the femur. Typically, a normal adult has an angle of inclination between 120 and 125 degrees. It is usually closer to 125 degrees in the elderly. An increase in this angle, greater than 135 degrees, results in coxa valga, and a decrease, or less than 20 degrees, is called coxa vara. The angle is widest in infancy and becomes lessened during growth, so that at puberty it forms a gentle curve from the axis of the body of the bone. In the adult, the neck forms an angle of about 125 degrees with the body, but this varies in inverse proportion to the development of the pelvis and the stature of the individual. The angle decreases during the period of growth, but after full growth has been attained, it does not usually undergo any further change, even in old age. It varies considerably in different persons of the same age. In females, the neck of the femur forms more nearly a right angle with the body than it does in the male. This is a consequence of the increased width of the pelvis. Coxa vara and coxa valga have some physical presentations. Coxa vara will result in a decreased hip-neck angle. The leg appears shorter, and the patient will appear to have genu valgum, which is where they look like they're knock-kneed. The patellas will squint, which means that they ride high and kind of look at each other towards the midline. Coxa valga is a result of an increased angle of the hip neck. The leg appears longer, and the patient will appear to have genu varum, which is where they look like they are bow-legged, and the patellas will have a frog-eyed appearance, which means that they sit laterally and high on the knee. The angle of torsion is formed by looking at the relationship between the axis of the femoral head and neck and the femoral condyles. The normal femur has an angle of torsion between 12 and 15 degrees. An increase in this angle is termed anteversion, while a decrease in this angle is termed retroversion. It is also important to note that both normal and abnormal angles of inclination and torsion are properties of the femur and exist independently of the hip joint. However, abnormalities typically alter joint stability. Anteversion and retroversion will also have physical characteristics in much the same way as coxa valga and vara do. A patient with anteversion will present with femoral internal rotation. They will present with the squinting patella, where the 2 patella appear to be looking at each other and shifted towards the midline. The patient will also walk with a toe-in gait, which is sometimes referred to as being pigeon-toed. A patient with retroversion will present with femoral external rotation. They will present with a frog-eye patella, where the two patella appear to be on the lateral side of the knee and sitting high. The patient will commonly walk with a toe-out gait, which is sometimes referred to as a duck or penguin walk. The innominate bones, the ilium, ischium, and pubis, unite in early adulthood at a triangular structure in the acetabulum. The acetabulum is a cup-shaped socket that forms the hip joint with the head of the femur. The ring made by the pelvic girdle functions as the birth canal in females. The pelvis provides attachment for muscles that balance and support the trunk and help to move the legs, hips, and the trunk. In a human infant, the pelvis is narrow and non-supportive. As a child begins walking, the pelvis broadens, tilts, and the sacrum descends deeper into the articulation with the ilia, and the lumbar curve of the lower back develops. The pelvis is vital to both locomotion and childbirth. The female pelvis has evolved to its maximum width for childbirth. In contrast, human male pelvises are not constrained by the need to give birth, and therefore are more optimized for locomotion. The principal differences between the male and female pelvises include: the female pelvis is larger and broader than the male pelvis, which is taller, narrower, and more compact. The female inlet is larger and oval in shape, while the male sacral promenology projects further. For example, the male inlet is more heart-shaped. The distance between the ischia bones is small in males, making the outlet narrow, but large in females who have a relatively large outlet. The ischial spines and tuberosities are heavier and project further into the pelvic cavity in males. A greater sciatic notch is wider in females. The iliac crests are higher and more pronounced in males, making the male pelvis deeper and more narrow than the female pelvis. The male sacrum is long, narrow, and more straight, and has a more pronounced sacral promenology. The female sacrum is shorter, wider, and more curved posteriorly, and has a less pronounced promontory. The acetabula are wider apart in females than in males. In males, the acetabulum faces more laterally, while it faces more anteriorly in females. Consequently, when men walk, the leg can move forward and backward in a single plane. In women, the leg must swing forward and inward from where the pivoting head of the femur moves the leg back in another plane. This change in the angle of the femoral head gives the female gait its characteristic swinging of the hips. The hip joint is a synovial joint formed by the articulation of the rounded head of the femur and the cup-like acetabulum of the pelvis. It forms the primary connection between the bones of the lower limb and the axial skeleton of the trunk and the pelvis. Both joint structures are covered with a strong but lubricated layer called the articular hyaline cartilage. The cup-like acetabulum forms at the union of the three pelvic bones, the ilium, the ischium, and the pubis. The Y-shaped growth plate that separates them is fused definitively at ages 14 through 16. Because so much of the head of the femur is articulating with the labrum, there is a greater stability but less range of motion when compared to the shoulder joint. The acetabulum grabs almost half of the femoral ball, a grip augmented by a ring-shaped fiber cartilage lip called the acetabular labrum, which extends the joint. The head of the femur is attached to the shaft by a thin neck region that is often prone to fracture in the elderly, which is mainly due to the degenerative effects of osteoporosis. The hip joint is reinforced by 4 ligaments, of which 3 are extracapsular and 1 is intracapsular. The extracapsular ligaments are the iliofemoral, ischiofemoral, and pubofemoral ligaments, which are attached to the bones of the pelvis, the ilium, the ischium, and the pubis respectively. All 3 strengthen the capsule and prevent an excessive range of motion of movement in the joint. Of these, the Y-shaped and twisted iliofemoral ligament is the strongest ligament in the human body. In the upright position, it prevents the trunk from falling backwards without the need of muscular activity. In the sitting position, it becomes relaxed, thus permitting the pelvis to tilt backwards into its sitting position. The iliofemoral ligament prevents excessive adduction and internal rotation of the hip. The ischiofemoral ligament prevents medial or internal rotation, while the pubofemoral ligament restricts abduction and internal rotation of the hip. The zona orbicularis, which lies like a collar around the most narrow part of the femoral neck, is covered by another ligament which partially radiates into it. The zona orbicularis acts like a buttonhole in the femoral head and assists with maintaining the contact in the joint. All three ligaments become taut when the joint is extended. This stabilizes the joint and reduces the energy demands of the muscles when we are standing. The intercapsular ligament is the ligamentum teres and is attached to a depression in the acetabulum called the acetabular notch and a depression on the femoral head or the fovea of the head. It is only stretched when the hip is dislocated and then may prevent further displacement. It is not that important as a ligament, but may be vitally important as a conduit of a small artery to the head of the femur, that is the foveal artery. This artery is not present in everyone, but can become the only blood supply to the bone in the head of the femur when the neck of the femur is fractured or disrupted by injury in childhood. The pubic symphysis, or the symphysis pubis, is the midline of the cartilaginous joint, uniting the superior rami of the left and right pubic bones. It is located anterior to the urinary bladder and superior to the external genitalia. The pubic symphysis is a non-synovial ampiarthroidal joint and comes from the Greek word symphysis, meaning growing together. The width of the pubic symphysis at the front is 3 to 5 millimeters greater than its width at the back. This joint is connected by fibrocartilage and may contain a fluid-filled cavity. The center is avascular, possibly due to the nature of the compressive forces passing through this joint, which may lead to harmful vascular diseases. The ends of both pubic bones are covered by a thin layer of hyaline cartilage attached to the fibrocartilage. The fibrocartilaginous disc is reinforced by a series of ligaments. These ligaments cling to the fibrocartilaginous disc to the point that the fibers intermix with it. There is slight movement available at the pubic symphysis. In normal adults, it can be moved roughly 2 millimeters and with 1 degree of rotation. This increases for women at the time of childbirth. This picture is a demonstration of the large ligamentous support of the pelvic girdle from an anterior view. This picture is a demonstration of the large ligamentous support of the pelvic girdle from a posterior view. The trochanteric bursa is at the top and outer side of the femur, between the insertion of the gluteus medius and the gluteus minimus muscles into the greater trochanter of the femur and the femoral shaft. It has the function, in common with other bursa, of working as a shock absorber and as a lubricant for the movement of the muscles adjacent to it. Occasionally, this bursa can become inflamed and clinically painful and tender. This condition can be a manifestation of an injury, often resulting from a twisting motion or from overuse, but sometimes arises for no obvious definable cause. The symptoms are pain in the hip region on walking and tenderness over the upper part of the femur, which may result in an inability to lie in comfort on the affected side. The femoral triangle is an anatomical region of the upper inner human thigh. The femoral triangle is bounded superiorly by the inguinal ligament, medially by the lateral border of the adductor longus muscle, and laterally by the medial border of the sartorius muscle. Its floor is formed by the pectineus and adductor longus muscle medially and iliopsoas muscle laterally. Its roof is formed by the fascia lata. The femoral triangle is important as a number of vital structures pass through it, right underneath the skin. The following structures are contained within the femoral triangle from lateral to medial: the femoral nerve and its terminal branches, the femoral sheath and its contents, the femoral artery and several of its branches, the femoral vein and its proximal tributaries, and the deep inguinal lymph nodes and associated lymphatic vessels. The hip joint is supplied with blood from the medial circumflex and lateral circumflex arteries, which are both usually branches of the deep artery of the thigh, the profunda femoris. but there are numerous variations, and one or both may arise directly from the femoral artery. There is also a small contribution from the foveal artery, a small vessel in the ligament of the head of the femur, which is a branch of the posterior division of the obturator artery, which becomes important to avoid avascular necrosis of the head of the femur when blood supply from the medial and lateral circumflex arteries are disrupted. For example, a fracture of the neck of the femur along the artery courses. The hip muscles act on three mutually perpendicular main axes, all of which pass through the center of the femoral head, resulting in 3 degrees of freedom and 3 pair of principal directions: flexion and extension, lateral and medial rotation, abduction and adduction, and a combination of these movements, which is called circumduction. Circumduction is a compound movement in which the leg describes the surface of an irregular cone.